Dr. Kassa, a neurologist with the Northern Neuroscience Institute, Husung Multiple Sclerosis Center. Today we're going to talk about pregnancy and multiple sclerosis. Before we continue, I would like to make a quick disclaimer. In this talk, we'll be talking about the off-label use of some multiple sclerosis drugs. Some of the information I will be sharing with you today is based on expert opinion and my personal opinion. It is very important to discuss plans to become pregnant when medications you are taking if you are pregnant, and the use of medications during breastfeeding with your healthcare provider. Today, we're going to talk about multiple sclerosis and pregnancy. Specifically, what do we know about the risk for having relapses when pregnant? What do we know about MS and breastfeeding? And what about the use of disease-modifying therapies, that is, medications to treat MS, for women planning to get pregnant, during pregnancy, and during breastfeeding? So, what do we know about MS and pregnancy? Before the 1990s, many women with multiple sclerosis were advised not to get pregnant because physicians were worried that it wasn't safe for people with multiple sclerosis. There was not very much data looking at how women with MS fared during pregnancy. Then, in 1998, there was a study called PRIMS that was published. This was a study looking specifically at the risk for relapses in women before, during, and after their pregnancies. This pivotal study showed that the relapse rate fell or was lower during pregnancy, especially in the second and third trimesters. This graph shows the annualized relapse rate, or number of relapses per year for women in the year prior to pregnancy, during the 3 trimesters of pregnancy, and after pregnancy. You can see that there is an increased risk for relapse after women give birth. In other words, this study showed that during pregnancy, risk for relapse was lower for people with multiple sclerosis. Other important findings in this study suggested that epidural anesthesia is safe for women with multiple sclerosis, which is great news. It is safe to get an epidural. Breastfeeding was safe for women with MS and didn't seem to make multiple sclerosis worse. Most importantly, the PRIMS study showed that there was no accelerated accumulation of disability at 1 year for women who got pregnant overall. In other words, women who got pregnant did not look worse later on compared to other people with multiple sclerosis. Several other studies followed the PRIMS trial showing similar results. So, if you remember, the graph from the PRIMS trial showed an increased risk for relapses in the 3 months after giving birth. Based on this data and the data from supporting studies, there are some known factors that increase a woman's risk for having a relapse after giving birth. This include relapse rate in the year before getting pregnant, or how active your disease is in the year before getting pregnant. Having a relapse during pregnancy is another risk, and having a higher disability score at baseline, meaning more difficulty walking, using your hands or manual dexterity, higher levels of cognitive dysfunction, or problems with memory or thinking. This is why many MS providers recommend that women go on medication and are stable with no relapses for at least 1 year before trying to get pregnant. What about multiple sclerosis and breastfeeding? The PRIMS data suggested that breastfeeding is safe for women with MS. Later studies demonstrated that breastfeeding appears to offer some protection against relapse of MS, and that women who exclusively breastfed their babies had a lower relapse rate and were less likely to have relapses in the postpartum period. This graph is from a study done comparing women who exclusively breastfed versus women who did not exclusively breastfeed, or breastfed but also supplemented with formula. This data showed that women who exclusively breastfed had a longer time to first relapse after giving birth, that is, decreased risk for having a relapse in the first 6 months after giving birth. We think that exclusive breastfeeding may decrease the risk for postpartum relapse by about 40%. What about disease-modifying therapies? That is, medications used to treat multiple sclerosis and pregnancy. This part of the talk includes some off-label information regarding MS drugs. Much of what follows is based on expert opinion and my opinion. In terms of injectable therapies, there is data on glatiramer acetate, that is Copaxone, and the interferon beta, betaseron, and Rebif in over 2,500 pregnancies. Based on this data, these drugs could be continued when woman is trying to become pregnant and either stopped when she has a positive pregnancy test or continued during pregnancy in some circumstances. We recommend that oral drugs should be stopped during pregnancy. The amount of time you need to be off these drugs depends on the drug. We call this the washout period. Drugs like Tecfidera, that is dimethyl fumarate, and Vumerity, that is diroximel fumarate, have a very short washout period. Drugs like Obajo, that is teriflunomide, and Mevenclad, that is cladribine, have a much longer washout period. Some drugs like Gilenya, that is fingolimod, and Mazen, that is siponimod, have a risk for rebound disease activity when stopped. This means that patients may have bad relapses when the drugs are stopped and should talk to their MS providers before stopping these drugs to find ways to reduce the risk for rebound MS disease activity. In terms of infusion drugs, Tysabri or natalizumab can either be stopped prior to becoming pregnant, and women may be switched to another drug, or Tysabri can be continued in some select cases during the first and second trimesters. Babies exposed to Tysabri in the third trimester are at risk for low blood counts at birth, especially anemia and low platelet counts. Stopping Tysabri when a woman has a positive pregnancy may put one at risk for severe relapse, that is a rebound during pregnancy. Women on Tysabri who want to become pregnant should discuss options with their MS provider and decide if they're going to continue the drug during the first part of pregnancy or stop the drug before becoming pregnant. For the drugs that work by depleting or killing adult B cells, lymphocytes like Ocrevus, Rituxan, which is sometimes used off-label for multiple sclerosis, and Kysenta, these drugs are unlikely to close the placenta in the first trimester. This means that the risk of a baby being exposed to the drug, if given just prior to becoming pregnant, is low. One can consider giving Rituxan or Ocrevus about 12 weeks before becoming pregnant. Rituxan, Ocrevus, as well as Kysenta, which is an injectable drug, in some circumstances can be considered to give closer to when a woman conceives. The nice thing about these drugs is that there is a longer-lasting protection against relapses and no risk for rebound, that is, severe relapses when the drugs are stopped. Drugs like Ocrevus or Rituxan can give protection for 6 to 9 months after the last dose. With Kysenta, there is protection from relapses for 3 to 5 months after the last dose on average. Finally, some MS specialists use these drugs as a bridge to protect women from rebound when they are stopping Tysabri or drugs like Gilenya. In terms of using DMTs in breastfeeding, many women opt to stay off disease-modifying therapy when breastfeeding. We know that exclusive breastfeeding is protective. Some drugs have limited data suggesting that they may be used in certain circumstances during breastfeeding. These drugs include the older injectable drugs like Copaxone and the interferons, which have been the most data from national pregnancy registries. Other drugs are sometimes used during breastfeeding, including Rituxan and Ocrevus. Women who opt not to or are unable to breastfeed should ideally restart medication soon after giving birth. In conclusion, pregnancy is thought to be protective in multiple sclerosis, and there is a decrease in the relapse rate, especially in the second and third trimesters. There is an increased risk for relapse soon after giving birth. Exclusive breastfeeding for at least 2 months offers protection against relapses. Finally, it is important to always discuss plans when considering to become pregnant and DMT use if you are planning to become pregnant, are pregnant, or are breastfeeding with your MS provider. If you would like to research further, here are the resources I used to prepare this presentation. To learn more about the Norton Neuroscience Institute Husung Multiple Sclerosis Center or make an appointment, go to nortonneuroscienceinstitute.com. Thank you very much for listening.